Okay, so I think we'll get started. Thanks everyone for your patience. Welcome to Heart and Stroke Presents. Today's webinar is titled Lifting Our Voice, Advancing Health Equity or Equity in Care for Women Living with Heart Conditions and Stroke. Just wanted to say that this month is also Heart Month, so this is our special Heart Month webinar. And we're actually also today starting Congenital Heart Disease Awareness Week. So just wanted to mention it, and we're really happy for everyone to join us to celebrate this important month. So I'll just start with a few housekeeping items, but so I think all of you are joining today's webinar through your computer audio. If you wanna join through your phone, you can just select phone call or call me and then follow the prompts. We really welcome questions during today's webinar, so you can enter them via the question panel, and please just enter them at any time during the presentation and they will be addressed. We'll have some time at the end, 5 or 10 minute period for questions and answers at the very end. And just want to mention that the webinar is being recorded. It will be available for online viewing after the event on Heart and Stroke's YouTube channel and also on our Stroke Best Practice website. Today, after the webinar, you'll also see a survey screen that will pop up and that will invite you to complete an evaluation, which will lead to certificates for your participation. So I just wanted to introduce myself. My name is Faubert. I'm the Director of Health Equity and Mission Impact here at Heart and Stroke, and I will be the moderator for the next hour. Before we begin, we also want to take the time to acknowledge the Indigenous peoples of all of the lands that we are on today. Even though we're meeting on a virtual platform, we want to still acknowledge or take the time to acknowledge the importance of the land in which we all call home. From coast to coast to coast, we acknowledge the ancestral and unceded territory of all of the Inuit, Métis, and First Nations people that also call these lands home. And for Heart and Stroke and for all of us, we do this to reaffirm a commitment, but also a responsibility in improving relationships with between nations, but also to improve our own understanding of local Indigenous peoples and their cultures. So we're gathered here today because of a shared commitment to health equity and equity overall, including reconciliation. And I really encourage everyone to reflect on what that means for you and for your work and in your life. So thank you again for joining today for our Heart Month webinar. Heart and Stroke is working really hard to continue to increase awareness and support for women with heart and stroke conditions, to also transform or continue to improve our health systems, to fund research and to advocate to ensure that women from everywhere around Canada receive the best care and treatment throughout their journey. Today's webinar we have 3 specific objectives. So first, we want to really discuss or better understand the current landscape and historical context of challenges that women living with heart conditions and stroke face in terms of accessing care. We will also have an opportunity to discuss ways to integrate gender equity into practice for healthcare professionals. And our third objective is to identify more practical strategies for healthcare professionals and empower women who live with heart conditions and stroke to advance equity in care and improve women's health outcomes. So our presenters today, it's a real pleasure for me to introduce you to our 3 guest panelists. So we are joined today by Dr. Inderveer Mahal. She's a family doctor with a focus on women with chronic pain in Vancouver, BC. We are also very lucky to have Barb Hess. She's a woman with lived experience, and she will share today her personal story to bring it to life for all of the attendees. And she's from Saskatchewan. And we are also joined by Dr. Andrea Lavoie, and she's the head of Cardiology in Regina, Saskatchewan, and she's also a heart failure specialist. So first, I'd like to introduce you to Dr. Inderveer Mahal. Again, as I mentioned, she's coming from Vancouver, where she practices as a family doctor. Dr. Mahal takes a holistic approach to treatment, and she has a specific focus on women with chronic pain. So I really want to welcome you, Dr. Mahal, and I'll pass it over to you.
Great, thank you for that Very lovely introduction. I want to start off by just thanking everybody for joining onto the webinar today, for wherever you are in Canada. My goal today is to talk about where women are in terms of cardiovascular and brain health care and how we can do better, but also highlight where we have learned the gaps are and where we can try and bridge those gaps to try and bring equity to the type of healthcare we provide to both men and women. I'm not sure if this is so much a conflict of interest, but I am a contributor to CBC Radio. I am a paid health columnist at times, but I could not see any way in which that would cause any conflicts of interest in this presentation, but I thought I would put it out there for clarity. And so I wanted to start off by the case of the missing female data. And so for those of you who may not know, women historically have been quite underrepresented when it comes to cardiac and cerebrovascular clinical research. And so what that means is all of the data that we've collected over the last 10, 15, 20, 50 years has had a disproportionate number of men in clinical studies. And then if we break that data down even more, there is a significant paucity of underrepresentation of racialized, BIPOC, and particularly transgender females. And that's really important because I would say of all of the areas of medicine, if we look at all of the specialties, cardiology actually has some of the biggest clinical trials. In fact, most other specialties are quite envious of the number of study participants that we can get into our cardiac studies. But we don't have equal representation with men versus female. And so what that means is that we don't have the clinical data to make the best choices that we possibly can for women when it comes to making clinical decisions. Most of the tests we use to diagnose a heart attack and a stroke were in fact developed and tested on men. And so one of the examples I really wanted to highlight is that when we look at our conventional coronary angiograms, they don't always detect blockages and dysfunctions in very small arteries. So we're looking at more at the major, medium, and large size coronary arteries. And those small heart attacks, so those very small artery involvement, often occur more frequently in women. And so we don't have that collected in our clinical data. And so what that means is that if you come into your family physician's office or into the emergency room, we in fact may miss a heart disease or an impending heart attack because the way it presents in women is different in men. And even when a female is appropriately diagnosed, we don't necessarily give them the appropriate treatment since most of the therapies that we have developed are in male-dominated research trials. And so you can see that even though we have all of this data that we've collected and large, well-powered studies, that doesn't translate equally across both males and females. And then once we get down to actually treating those heart attacks, when we detect them, we see that women are actually at a greater risk of drug-induced heart rhythm disorders or arrhythmias. And when you do go for an angioplasty or a procedure, we see about a 30% greater risk of bleeding complications. And so the challenge is that when you're missing that data and you have clinical research that doesn't sex stratify results, meaning we don't break down the results based on gender, we don't have equity in the way that we look at cardiovascular disease management and cerebrovascular disease management in males and females. And I think this point will resonate for many of us who are listening because I was guilty for it as well when I was going through medical school. We don't think of heart health when we think of women's health. We think of things like breast cancer and pregnancy, but rarely do we think about heart failure, cardiovascular disease, post-stroke care, and what that looks like for women, particularly as they move through their 50s to 80s. And so really ensuring that we don't just think about heart health as a male diagnosis and a male disease, but we think about it for both genders is really important. Now, I also wanted to highlight what the consequence of not equally studying female cardiac and brain pathology means. It means that when we develop clinical tools, we look at risk stratification and we develop clinical protocols, they are shifted more towards the male gender. And like I said in my last slide, Males and females do not necessarily present with heart attacks and strokes in the same way. So when patients come into the emergency room, our classic training in medical school is that you get that left-sided chest pain, you might get shortness of breath, they might be sweating and diaphoretic. But in females, we actually might see more of a presentation of nonspecific abdominal pain. They might feel dizzy, they might feel lightheaded. And so that classic left-sided chest pain is not always consistent with females, and even less so with racialized females. And again, that classic triad, when we think of a presentation of a heart attack or an NSTEMI, is based on data we collected from male participants. And so the clinical tools and risk stratification for that acute presentation of a STEMI or an NSTEMI, and I apologize for the medical terms, I should say heart attack here, is based on what a typical male may present with. And in fact, you know, I remember going through medical school over a decade ago now, and we would talk about atypical presentations of chest pain, and we would say females are more likely to present with atypical chest pain. But what we know now is, in fact, that this is not atypical chest pain if you come in with abdominal pain or vague feelings of discomfort or lightheadedness. It is a spectrum of how heart attacks can present in the emergency room and in the family doctor's clinic. And so we really need to rethink the way that we imagine what a heart attack or even a stroke can look like, just based on the fact that, again, a lot of that data came off of our male participants. I wanted to touch on the fact that our medical school curriculum, but probably a lot of our other allied healthcare professions also do a poor job of teaching gender-specific risks. And so there are certain periods in a woman's life where a risk of a heart attack or a stroke goes up, particularly during pregnancy and postmenopause. And so those risk factors that are classic in increasing the risk of heart disease or stroke, like smoking, and diabetes, aren't weighted equally across a woman's lifespan. And so we need to do a better job of really teaching our health professionals that the risk of a heart attack and stroke can change throughout a woman's life. We know absolutely without a doubt that physicians are better at diagnosing heart and brain disease in men and women. We've shown that time and time again in our clinical research. And we also know that our treatment strategies aren't necessarily as effective in females as they are in men. And there are certain cardiac medications that are actually less effective and some that develop more side effects. And again, a higher risk of bleeding post-angioplasty in females as well. So again, the consequences of that missing data means that half of women who experience a heart attack can have their symptoms go unrecognized. And that's a huge number. So imagine 50% of the population not having their heart attack recognized. I mean, that's a massive number. And that's part of the reason why we are putting on this webinar, because it continues to be a problem that we experience in our healthcare system. We know that when they do experience a heart attack, they're less likely than men to receive the treatments and medications they need to get them or get them in a timely way. And we know that women are more likely than men to die in the year following a heart attack. And Dr. Lavoie will probably touch on this later on in her presentation, but women who develop a heart attack are more likely than men to also develop heart failure in the subsequent 5 years. So that's one of the major consequences of a heart attack, is that the heart does not function in the way that it used to. And so we see that higher and more often in females. And sadly, women who experience strokes are at a higher risk of dying than men. And if they do survive, we see their outcomes are worse as well. And so given all of that, it actually isn't surprising that heart disease remains the #1 cause of preventable death amongst Canadian women. And part of that relates to the missing data. Part of that relates to the fact that our clinical protocols and the way we diagnose heart and brain disease in women is not on par into the way that we do with men. And then part of that remains with the fact that we don't think of heart disease as a woman's disease. We think about it in terms of something that affects males more than females, when in fact that is not the case. And so really shifting the conversation, educating our general population, but also educating our health professionals about what I think it tends to be a little bit of a myth that perpetuates our curriculums is really important. I wanted to just demonstrate some of the articles that have come out over the last 5, 10, 15 years about really how gender can impact heart disease and risks, and you can see that it can be racial and ethnic minorities that are particularly at risk, and we see that heart disease risks in females is actually one of the most preventable causes of death, and so we are starting to see the media and the research studies capture that. I know I only have 5 minutes, but I really wanted to hone in on just the gender roles and societal expectations and how that influences women and heart disease. And so I think for many of the females and also the males who may be here in this presentation as well, this probably resonates with you. Females tend to have more caregiving responsibilities, and as a consequence, they tend to prioritize the needs of their family members, their spouses, their children. We have seen it in the research studies that women play a much larger role in household management, so unpaid labor, even if they work full-time outside of the home. And so when it comes down to time, they really have a limited ability to focus on their own health. I've seen this in my own practice as well. Sometimes the way females communicate can really prohibit what we call self-advocacy. So they might have more of a passive style, they may be quieter, and sometimes when females do advocate for themselves, it may not be looked on positively like it may be in men. And then we also see the way that they engage in cardiac rehab programs is less so than their male counterparts as well. I particularly wanted to highlight the ethnic and racial risk factors. We've seen that our federal government has announced that we'll be bringing in over 500,000 immigrants over I think it's on a year-to-year basis. I may have gotten that exact number wrong, but it is quite a significant amount. And so we're going to see what the average Canadian looks like, and their demographics start to particularly shift and change. And so that means we really have to start to look at how women from racialized backgrounds have a higher risk of heart and brain disease because of their genetic predisposition. So South Asians, Afro-Caribbean, North American Chinese, and Hispanics, we see all of those groups have a higher risk of heart disease, higher incidence of heart disease as well. And then also important to recognize that anti-Black racism in Canadian healthcare spaces can actually lead to Black Canadians not wanting to engage in the healthcare system either. And so we actually had a quote from the CMAJ by Black medical students and physicians across the country, and they said, "Systemic anti-Black racism is so deeply entrenched in our healthcare system and all aspects of medical training for admissions and assessments to the everyday discrimination experienced by Black medical students and physicians." And so these are people who exist in our healthcare space in a position of privilege. And so you can imagine if that is their experience, put yourself in the shoes of a patient who has to navigate this system. And you can see how challenging it can be to get the care that you need. And then I think really important to highlight that we have absolutely no clinical guidelines specific to ethnicity, despite these much higher risks in our racialized populations. We know that racialized women also have more barriers to healthcare accessibility. So, I know this is not pertinent to all females from these backgrounds, but historically they come from a more paternalistic culture. And so what that means is they haven't necessarily been taught to self-advocate, or may have actually been taught to not self-advocate. Their communication styles may not fit our usual North American norm. So things like eye contact, raising their voice, using words and language that have a focus on self-advocacy and describing their symptoms. And in fact, it's actually been found that females from racialized backgrounds tend to describe their symptoms more in terms of mental health descriptors than physical symptoms. And so that can definitely take you down away from the route of organic pathology and have you focus as a clinician on mental health when that may in fact not be the case. Depending on where you live, you may have difficulty with English or French, and of course, uncertainty in how to navigate the healthcare system here in Canada if you are new to the country. I think this is something we can all appreciate with the rising cost of inflation, but rising food costs, housing, limited childcare, all of those things limit a female's time and focus on self-health. And if you are living at or below the poverty line, especially if you have to provide for a family, that really inhibits your ability to participate in primary and secondary prevention of heart disease. So making those healthy choices, making those heart-healthy dietary decisions can be much more challenging. And if you have a history of trauma and violence, of course, that makes you more hesitant to access healthcare. And then I have done some work on our downtown east side here in Vancouver, and particularly if you have a substance use disorder, there can be a lot of stigma that exists in our healthcare system that can make your symptoms not go recognized. So what can we do? So I think I've just about run out of time. As we can learn about the gaps in our clinical decision-making tools that put women at a disadvantage. For those of you who function in healthcare systems, build your local healthcare systems to work with, not against the barriers that keep women out of the healthcare system, and know that all women will not self-advocate. And I think this is the most important part that I want to highlight, is that language, learned behaviors, and time limitations are all barriers for females. And if you can take back the information you've learned today to your local health authorities and individuals in leadership, I think we will all be one step further in trying to support women in accessing the care that they need. And so really my key message today is that we have gaps in our research in how to best prevent, diagnose, and treat women with heart disease and stroke. We have very specific further barriers for racialized women. And I also want to say that while much has to be improved, I think there is a lot of work that we have already started to do, particularly with the help of Heart and Stroke. And I very much appreciate that it continues to be a mandate by the Heart and Stroke Foundation to further women's health in cardiovascular and brain care.
Thank you, Dr. Mahal, for bringing to life all of these gaps that we know in research knowledge. Also, you talked about gaps in tools to prevent, diagnose, and treat women's hearts and brains, but also for highlighting some of the additional barriers that we know some racialized women and women from other equity-deserving communities are facing. I think there's been some noise, I think, when I was speaking at the beginning. I hope it's resolved, but I apologize in advance if it's still there. So we will now hear from Barb Hess. So I'm really pleased that Barb is joining us. Barb is a 49-year-old, married mother of 2 university-age kids. Prior to her diagnosis, she had a long career with TD Bank, spanning over 30 years, and she was most recently with TD Wealth before having to retire earlier due to health issues. She's here with us today to speak on the other face of heart disease. So welcome, Barb, and over to you.
Thank you, Christine, for the introduction. Good afternoon, everybody. Today, I'm going to be talking to you about my experience with microvascular disease from the patient's perspective. My journey with heart disease started in November of 2018, shortly after my 45th birthday. I woke up on a Saturday morning not feeling well, but I just returned late the night before from a work conference, so attributed it to that. Continued to feel unwell all day. By the evening, we decided to go to my husband's Christmas party. Thought, we'll leave after supper if I still don't feel well, which we did. Went to walk the 1 block to my vehicle, and about halfway, I ended up doubled over with crushing chest pain. Managed to make it to the vehicle, said to my husband, you know what, I'm just tired from the week, we'll just go home. We almost got there, but then he pushed me to go into the emergency, so off we went. They did all the standard heart tests, which of course didn't show anything. I was given morphine through IV, which ended up stopping my breathing, actually. If you can imagine a wave coming from your diaphragm up and stopping your breathing, that's what it felt like. They reversed it very quickly with another drug, and then they had me breathe into a paper bag. After that, I was told to go see my GP for anxiety meds and sent home. So I knew it wasn't anxiety because I'm not an anxious person. So a couple of weeks later, I continued to feel unwell, went in to see a GP that works with mine because I couldn't get into my particular one. He said he would order blood work and a stress test and then call me, and I never heard from him again. While I waited for my stress test, though, my husband had chest pain at work, went into the ER. They ran all of the same tests and then ordered a stress test, which he was given within a week while I continued to wait. So you fast forward a month into the middle of January, and again, I had crushing chest pain. So my husband comes and takes me to the ER a second time. They do all of the same standard tests. Again, nothing shows again, of course. So what I was told is there's nothing imminent, so go see your GP. So what that translates though to a patient to mean though was there's nothing wrong with you, so get out of my ER. I knew still something wasn't right because I went from being somebody who could run on the treadmill on a regular basis to not being able to walk the 2 blocks from my vehicle to my office without being out of breath. So luckily I happened to have an appointment with my regular GP the following week. I told him what was happening and how I was feeling. So he called to find out where the stress test was at. He also mentioned, though, that he didn't think it would show anything, but we'll do it to rule it out. This was like a Wednesday. The appointment got booked for the Monday morning early. That weekend, even just those few instances that I had, that weekend, I thought, you know what? I don't want to go. I'm just going to be wasting their time. It's just all in my head. I said to my husband, you know, but I went out of sheer politeness, as I knew they wouldn't be able to fill that spot on a Monday morning with that short of notice. So when I did go in for the stress test, 4 minutes into it, the doctor shut it down. So I had always exercised. I was all proud of myself, honestly, thinking that I had knocked it out of the park. I couldn't wait to get home and show my husband that I had passed it faster than him. So you can imagine my surprise when the doctor said to me, the back section of your heart wasn't getting blood, and I'm sending you in an ambulance within the hour to Regina for an emergency angiogram. So it clearly didn't register for me. As well, I was being wheeled over to the emergency department. I did what I think most women do in multitasking. So I was calling my associate to reschedule my next few days and planning for coverage. I was making arrangements for my teenage kids since they would have no parents for the week. I called my husband, who had just boarded a plane in Toronto, heading to Ottawa for a conference for the week, and told him that I had failed my stress test and I'd be in Regina for a few days. So do you think when you come back on Thursday, you could give me a ride home because I won't have a vehicle? So clearly I didn't understand the severity or the importance of where I was going. He obviously, the poor man ended up taxiing down the runway, having to hang up, and nice way to send your husband off to on a plane ride. But he got to Ottawa, turned around, and after a super relaxing flight for him, and flew all the way back. We spent the week in Regina doing test after test, and they all came back fine. Lucky for me, though, I landed with Dr. Lavoie, who had experience with microvascular disease and didn't dismiss me. Finally, somebody who believed me when I said that something wasn't right. We spent that first year doing more tests to rule things out, as well as trial and error with medications to see what would and wouldn't work. My symptoms escalated extremely quickly, where my husband would drive me to my office and pick me up so I wouldn't have to walk. He took on all the grocery shopping after I had to call my family for reinforcements more than once. Imagine being something as simple as grocery shopping being too difficult to do by yourself at 45 years old, but that's where it became for me. I remember getting partway through the store and having the realization that I wasn't going to be able to finish by myself, but here I've got a cart full of groceries. I looked at my watch and realized I had my 16-year-old son was just finishing school. So I had to call him to come and help me to be able to get out of the store. So my family basically had to look after everything on the home front, as I would come home and collapse on the couch for hours, unable to function. Weekends, I wasn't somebody who'd ever had a nap in my life. Weekends turned into 3-hour naps because I was so exhausted. So as we were rounding the corner to the 1-year point, I got to the point where I was using nitro spray prior to every client meeting just to get through that meeting. I started sleeping in my recliner chair because I couldn't breathe when I laid flat in bed. Even with, though, feeling this low, Dr. Lavoie still had to convince me to take time off. And good on her, she had her work cut out for her. But until we could do the coronary reactivity testing to confirm my diagnosis, I think women have a really hard time putting themselves and certainly their health first, which is why so many times it does end tragically. I waited from November of 2019 until March of 2020 to get that testing done, to realize we discovered the severity of my particular case. I'm fortunate now that I know what I'm dealing with, but for me, this disease took away a career. It also took away my ability to plan things. So when I try to show other people to understand the unpredictability of this disease, I equate it to not knowing from day to day how much energy you have to work with. So one day I can wake up and your body will go along with what your brain thinks. And other days I use this analogy where your brain says, we need to do a thing. And your body says, no, you did a thing yesterday. That's enough things. So that's to give you an idea of what it's like on a daily basis. You never know what you can and can't do because it's very up and down. One of the biggest mental adjustments that come with this diagnosis is accepting that you can't do the things you did previously. The life you knew before is gone and you now have a totally different reality. Getting the proper diagnosis is only the first piece of the puzzle. The second piece is learning how to manage the disease. I was referred for the cardiac education, but I found for myself that it was focused on those who were recovering from a heart attack or a stroke, but it really didn't pertain to my particular diagnosis. So this particular diagnosis felt very isolating because I didn't know anybody else who had it. So therefore, there wasn't anybody to relate to or discuss symptoms with. So fortunately, through Anita at Heart and Stroke, that's no longer the case. She was able to connect me with somebody recently with a similar condition. So I thank her for that. I've now learned how to manage my condition much better, but it's taken me over 4 years. I still have chest pain and pressure, pain down my left arm, fatigue, along with shortness of breath daily. For me, it's a matter of to what degree. So I deal with brain fog, and when the chest pressure gets too great, I get a raspy voice, which you're all enjoying today, which according to my family is also my biggest tell if I try to say that I'm fine when I'm not. One of the things this past year that has helped me, though, is working with a nutritionist to reduce sodium and sugar intake. So much is hidden in the food that we eat without realizing it. When you're diagnosed, you're told to reduce sodium, but you aren't shown how. So I have found a program that works for many things, whether it's reducing sodium, sugar, or if needed, weight loss to reduce the stress in your heart. That piece can be a really huge challenge where you're used to being able to work off a bad choice or two. When this condition strikes, that option is no longer there. So learning what to eat and what combination and how much sounds like it should be super easy. But if it was, we wouldn't have a weight loss industry that's the moneymaker that it is. So, I mean, education is key and it doesn't have to be difficult or overwhelming. One area that I would say could be improved upon is access to supervised exercise. I was referred for it, but it wasn't offered in my particular area. So I spent the first few years terrified because I didn't know what my new limits would be. When you're first diagnosed, you don't know if walking 3 blocks or walking 10 blocks could cause you a heart attack. You know, there's a very unknown gap there. So, and I still actually truly don't know what I can and can't do. So my family gets dragged out with me if I go outside for a walk, and they know that. But certainly that's a new reality with a heart condition as well. So I think in closing, what I'd like those who hear my story to come away with is that first, as we spoke to earlier here, that we all have biases of what we think heart disease looks like. Prior to my diagnosis, I would have said it was somebody who was overweight, didn't exercise, poor diet, too much stress in their life, high blood pressure, maybe smoked. And I also would have said it was generally a man. Even the fantastic family doctor that I have said I was the last patient you would expect. So I can understand why then when I walked into the ER, the first thought wasn't heart. I was fit, I ate healthy, I exercised, I never smoked in my life. The occasional drink, low blood pressure. The only factor that I had working against me was a family history. I had a grandmother who passed away of heart disease in her 60s. And then the second takeaway I would say is listening to the women, and the automatic response to not be, it's just anxiety. When my husband went into the ER, even when he passed his stress test, nobody suggested he might be anxious or stressed, and certainly didn't suggest to go to his GP for anxiety meds. Women are busy with kids, spouses, careers, and running households. If they do make the time to come and see you, please listen to them. I assure you the last place they want to be, or certainly have time to be, is in your ER or in your office. They have a very long to-do list that usually trumps their personal needs. So the reason I'm telling my story is to maybe show a little bit of a different side of what heart disease can look like. Because I know that if my condition itself and my experience could have gone a very different way had I not landed with Dr. Lavoie and she listened to me. So she won't remember this, but on one of the visits, she walked into the room and said, "Teach me something." So what a breath of fresh air that was to hear as a patient. So now I can tell you all the great pieces of advice she's given me over the past 4 years, and there are many of them, but I'll let everybody grill her during the Q&A for her nuggets of wisdom. But I hope my story gives pause to those treating women and sheds some light on a condition that I think is likely underdiagnosed due to the lack of awareness of it. I also hope it encourages other women to keep pushing when they know something is wrong and they get turned away. So thanks for your time, everybody.
Thank you, Barb, for sharing your very, very inspiring story, but also for helping us understand the reality that it seems like many women in Canada are facing. So thank you for joining us today. Finally, I'd like to introduce Dr. Andrea Lavoie. Dr. Lavoie specializes in heart failure, and she's the head of cardiology in Regina. She takes a heart-centered approach in our research, teaching, and volunteer work, and we are very excited to hear from her today. So welcome, Dr. Lavoie, and over to you.
Thanks, Christine, and thanks so much, Dr. Mahal and Barb, for your excellent work and discussions here today. So we're going to move forward, and I'm just going to get you to advance my slide for me. So these are my disclosures. I do a lot of teaching with physicians in the community. Next slide. So Dr. Mahal spoke a lot about this. 1 in 3 women die of heart disease, and really this kills more than all cancers combined. So 1 Canadian woman dies of heart disease every 20 minutes. That means while we're talking today, 3 Canadian women will die from heart disease. 2 in 3 women who die of heart disease are said to have no warning signs. And so really this describes to us that we're often missing the early heart attack signs in about 78% of women. And Barb has some great descriptions of how in her case, you know, things were not exactly the same, both in the way that she experienced the system and then what happened subsequently. And next slide, please. So we're going to talk about another story. You've heard Barb's amazing description about microvascular disease and heart failure that she experienced. Here's another story that to tell of another Saskatchewan woman from rural Saskatchewan who had, again, no risk factors and experienced 9 months of worsening shortness of breath and chest pain radiating into her back. And the reason why I want to bring this up is her daughter actually kept watching her and was on a walk with her at Thanksgiving and said, you know, Mom, you just really seem more short of breath. This doesn't seem right. You know, I've heard that women can get different experience heart disease differently. I really think you should get checked out. So she actually ended up also being referred for a stress test, which was abnormal. And she came for an angiogram with us. This time she had severe coronary artery disease and heart failure and was sent for urgent bypass. But she really, talks about her daughter being very important in her diagnosis. And so I think the importance of us not only listening to ourselves and advocating for ourselves, but also the loved ones around us. Next slide, please. So we're going to talk a little bit about congestive heart failure today. Next slide. Why are we talking about heart failure and what's the importance? And this is just one thing I thought was very important to bring to this community to talk because heart failure is an epidemic. It's one of the fastest growing cardiovascular conditions in the world, in fact. More than 100,000 Canadians are diagnosed with heart failure each year. And in Canada, heart failure is growing due to our increased aging population. We're also seeing more young people being diagnosed with heart failure. And we're also seeing a dramatic increase of heart damage done from COVID-19. And I'll talk a little bit about that. So 4 in 10 Canadians don't even know what heart failure really means. And so we really need to understand what is heart failure, why do we have to talk about this, and how does that impact women? How do they access the system? Because we know that can be different compared to men. Next slide, please. So I bring this forward. Next slide, please. That heart failure and COVID-19 are very, it's very prevalent to see heart failure after an episode of COVID-19. So it's important to watch for symptoms. And I want to bring this to all of you this morning because there is such a high prevalence of this in the community. So we know from this trial that increased burden of heart failure in the year after a COVID-19 positive test, even if you have mild symptoms, is quite elevated. And in fact, in the year following a positive test, about 12 out of 1,000 people that get COVID-19 will end up with heart failure. And so if we think about Saskatchewan, for example, where there's 1 million people, that's 12,000 new diagnoses of heart failure. Next slide, please. So what is heart failure really? Well, it's when the heart just doesn't pump properly. And there are two main types. The first is where you have a preserved pump, but your heart actually gets stiff and it can't relax as well. So the blood backs up onto the lungs and make you feel short of breath. And this is caused by things like high blood pressure and diabetes. This type can actually be harder to diagnose, and it's much more common in women than men and as women age. So that's something that I think is important for you to know about. We also get pumps that don't work as well. And so this is where the heart muscle itself gets weak and it doesn't squeeze properly. The two most common causes are heart blockages and viruses. And this is where we see COVID-19. So women, again, are much more likely to have a misdiagnosis of heart blockage, which we heard about in Kathy's case, which can lead to heart failure. Next slide, please. So I want you to know what heart failure looks like and what it can look like in women. So this is where we see shortness of breath with activity, or especially when you're lying down at night. You can develop swelling in your legs, ankles, and feet as that fluid backs up. Sometimes you can experience a rapid or irregular heartbeat. You can have the reduced ability to exercise. You can have a persistent cough or wheezing, and this is again worse when you lie down often. You may experience fatigue and weakness, a rapid weight gain from fluid buildup. Sometimes you can have nausea and lack of appetite and difficulty concentrating, and Barb talked a bit about this brain fog as well as decreased alertness. And then, of course, if heart blockage is part of this or heart artery disease, chest pain can occur. Next slide, please. So we heard a bit about the fact that women do tend to present with different types of pain. We also tend to describe our pain differently. So women are more likely to have pain between their shoulder blades, whereas men describe it more in their middle of their chest. You can have both. Women are more likely to have neck and jaw or chest discomfort. Shortness of breath, fatigue, and nausea, those kind of stomach symptoms can be more common. upper stomach, and then back pain as well, as I mentioned. Women, however, are much less likely to say one specific thing and may describe a number of things, and that is not well discussed in med school. So oftentimes people kind of get distracted by some of the other things that women are describing. We also know that there's specific risk factors, and we touched a bit about this. So there's a number of areas in pregnancy that can actually increase your risk. If you've had preterm delivery, if you experience preeclampsia, if you have high blood pressure in pregnancy, you will have a higher potential risk of developing heart artery blockage in the future, as well as diabetes and diabetes in pregnancy, patients with polycystic ovarian syndrome, as well as menopausal status can increase your cardiovascular risk, hormone use, autoimmune disease, and also breast cancer treatment can be associated with heart failure as well. Next slide, please. So we heard half of women who experience heart attack have their symptoms go unrecognized, and when they're recognized, we actually see that they're less likely to be treated or get treated in a timely way. And they're less likely to be referred for cardiac rehabilitation even after they've had an event. And for many reasons that we heard earlier, are less likely to attend because they're taking care of everybody else and don't feel like it's worth their time to go to cardiac rehabilitation, which has real benefits in decreasing the chance of heart attack and death in the future. Next slide. So women are more likely to perceive heart symptoms as stress and anxiety, interestingly, and we talked a bit about that. 53% of women reported that their provider didn't think their symptoms were heart related. And again, Barb expressed, this multiple times in her experience. Women often dismiss their symptoms of heart failure as just being out of shape. And it must be just because I'm out of shape that I'm feeling so short of breath. Women having a heart attack have different causes compared to men. So this is, we think about Barb's diagnosis. Oftentimes with women, their cause of heart attack may not be as easily seen on our usual angiogram or the heart dye test. So women can have what we call ischemia with no obstructive coronary disease, meaning we don't have the usual atherosclerosis or big blockage blocking the way of blood flow, but instead we have disease in the very small blood vessels or an abnormality in the way that our arteries function. So it can look normal unless we do specialized testing that's only done in a few handful of centers across the country, but is so important to better understand. Women also are at increased risk of having tears in their artery, which is a different cause, and that can also cause aneurysms in other parts of the body as well, leading to stroke or kidney troubles. So these are all really important aspects. So we really have to look at understanding the needs of people with lived experience. And this is, Barb kind of expressed that in my discussion with her, like, teach me, how do I help you? Because I know how challenging and frustrating it could be in our system because we don't truly have a good understanding or even treatments in some of the instances of the causes of heart disease and heart failure. So it's really important for us to focus on how do we improve cardiac rehabilitation and also prevention. How do we address the specific needs for women? For example, peripartum care, discussing symptoms that may occur during that, palliative approach to care. So really looking at how we can help patients who are nearing the end of their life. Also addressing mental health issues, which we know across the board has been so challenging in these times, and looking at how they might be able to support their families and afford medications. Next slide, please. So there's also two specific communities that I want to address. The first being in rural communities across Canada. It's really important to address the problems and symptoms of heart disease quickly, as we've heard about. But there's often a shortage of primary care in many rural communities. Oftentimes, emergency rooms can be closed, or people have to travel long distances to access heart services or healthcare. And so that is one of the barriers that can occur when one lives in a rural community. So getting to see specialists often means you have to travel long distances. And I know I had someone here this morning that drove 4 hours and had to come up the day before. Sometimes there's no bus or transport or way to get out of communities. Communities in the north, obviously, much more challenged in this transport issue. So we need to look as a team at creative and innovative ways of delivering high quality care to every Canadian. And so I want you to think of ways that you can be a part of the solution in improving healthcare in Canada. And this is at the individual level, in your community, whether you're a healthcare worker, physician, or whether you're just a part of the healthcare system or care about it. It's really going to take all of us to address this problem and to try and help improve the outcomes of women with heart disease. So one quick example would be learning CPR. I think that's an important, as it may take, if you have someone whose heart suddenly stops, that first responder on the street might be you, or it might be you that needs it. And so this is just one of the ways that we as individuals can try and help. Next slide, please. I also wanted to talk briefly about Indigenous people. Now, certainly, as Dr. Mahal expressed, there is a lack of understanding in terms of our research in this area. But we do know that Indigenous people are much higher risk of heart disease and stroke compared to the general population. And as an Indigenous person, there's actually a higher chance of dying from heart disease and stroke if you're younger compared to the general population, or if you're a woman. But much more research and treatment and strategies need to be looked at. In my own practice, I've certainly seen that access to care is extremely difficult, especially if you're living on reserve. So it's, much more difficult to get transport to appointments. It's further from primary and specialty healthcare and pharmacies, and isolated. It's often patients have limited access to cardiac and stroke rehabilitation as well. So I believe that there's much work to do to try and improve the heart health of the Indigenous people. Next slide. So what can we do about this? Well, my spur on is take action and lift your voice. You're a part of our heart team, each and every one of you. So talk to your loved ones about the symptoms of heart disease in women. Educate each other. Don't ignore the symptoms of heart disease in yourself. It's actually a very common thing that occurs. Talk to your doctor if you know if you have risk factors for heart disease, and try and work on those. Tell someone to seek medical attention if you learn that they have symptoms of heart disease. And learn the signs of heart disease, such as heart attack, stroke, heart failure. An example, making changes, as I said, at the individual or community level is extremely important. And moving forward, understanding if I get chest discomfort, if I have something strange happen, shortness of breath, sweating, upper body discomfort, lightheadedness, just call 911 right away. It's better to be safe than sorry, and we're here for you. So if Kathy's daughter hadn't known the signs, her story might have been very different. So learn the signs of heart disease, lift your voice, help us make a difference in heart disease in women in Canada.
Thank you so much, Dr. Lavoie, for these very insightful perspectives. I think we've learned a lot on the gaps in terms of awareness, knowledge, research, clinical tools, and also thanks for raising from some of the important barriers that some of the communities from rural communities, Indigenous women face across the country. That's really important to know. I'll like to invite, so we have our three panelists back on the screen. Thank you just to join us for the question period. So thanks everyone who submitted questions in the question panel. We have, I think, 8 minutes, so we'll try to address a few of them. So wanted to start maybe a question for you, Barb. And Barb, I don't know if you want to just mention your specific diagnosis. Some people didn't hear what it was, but the first question I think is also relevant to, maybe we start with you and then we can open it up for Dr. Lavoie and Dr. Mahal. But what advice do you have for women who are concerned and they know something's wrong, with their heart or their brain, and they feel that, the physicians are not listening to the patient or to themselves, and or feel that they're not taking the situation seriously. So what would be your advice, or what would we do? What would you tell women in that situation?
Oh, goodness. Well, that's a tall order. I think that's why we're having the conversation today, because it does have to change. But I think you keep pushing. If you go to one and you get dismissed, you keep going back and keep repeatedly going back until somebody listens. And, I was fortunate that it was only a couple of months, really, seemed like a long time at the time with the way I was feeling. But before I was lucky enough to land with Dr. Lavoie, I know it could have been different. When I spoke to another woman just recently, she went 10 years. And she was much younger, almost 10 years younger than myself. You know, she went 10 years through 7 cardiologists and many doctors before she was listened to, but she kept going, kept talking. And then, you know, she discovered Dr. Sedlik out of Vancouver, who had experience and has gotten her some help. But you just got to keep pushing. Eventually you'll find the right person that will help you.
Thank you. So trusting your gut, basically, and just perseverance. Yes, thank you. Dr. Lavoie, Dr. Mahal, I don't know if you want to add anything from your perspective. Like, what would you advise women to do in that situation?
Do you want to take that first, Dr. Lavoie?
Sure. Yeah, I think being persistent and using, you know, some of the ways that you describe things is really important. And also saying, I think this might be my heart. I feel like I might have heart disease. Those words are actually really important for clinicians to hear, because they might have a few different things. Oh, maybe it's their stomach. Maybe it's their, you know, maybe they've got back pain problems or something. But I think if you have a feeling that something is wrong, and it's, those things can be very helpful in trying to express, and just keep at it. And I agree with Barb, just be persistent if you think that there's something wrong. And really, we're still learning about a lot of these newer understandings of heart disease. And so it's important for us to really understand when to pay attention, and we're trying to listen.
And you know, by the time my patients get to a cardiologist like Dr. Lavoie, you know, usually there's a relationship associated with symptoms and the heart. From the perspective of a family physician, I think Dr. Lavoie, you know, you just nailed it. You said, I think this might be my heart, or can you give me a reason why this couldn't be my heart? And sometimes that type of questioning can actually facilitate a conversation where your family physician might explain why they really think it may not be your heart, and that can alleviate the worries. Or it might trigger your family physician to think twice and say, well, you know, is there a reason I'm not ordering that stress test or a Holter monitor to take a closer look? And so sadly, sometimes it's the way that we phrase things and the way that we communicate. And you know, I just want to bring that back to, you know, my slide where I talked about that not all women have that capacity or the ability to self-advocate. So if there are family physicians or other healthcare professionals listening, just know that everybody doesn't have the ability to self-advocate. But hopefully through webinars like this, we teach our health professionals, but we also teach our women how to ask the questions to maybe get the results that they need.
Thank you to the three of you. And the next question, maybe, I wonder if Dr. Mahal might be for you, but someone was asking if there's programs in the community that can support women, and what these programs, you know, what should they look like if they don't exist currently?
Christine, I'm just going to look for that question here just to make sure I have the right one here. Let's see.
Do you want me to repeat it, Dr. Mahal?
Sure, yeah. Yes, just so I'm answering the right one.
So wondering if there's programs currently that exist in the community to support women to kind of like be heard and you know, facing those challenges that we've heard today. And if they don't exist, what could they look like? Like, what should they look like?
Yeah. So, you know, part of my practice, I work at the BC Women's Complex Chronic Disease Program. So we focus a lot on chronic fatigue and fibromyalgia. And it's not just women who participate in this program, but it's largely women. And even here in our program, we don't have a female-centered support system to help females navigate the healthcare system or help advocate. So I wish I was able to give you, you know, 1, 2, 3, 4, 5 programs that are available. Even in my area of practice, I don't have any examples to share of that. I do know there are some nonprofits that will help women or all Canadians navigate the healthcare system if they feel like they don't know how. But that is absolutely a gap and something we do not have available. And if there's anyone on the webinar who is aware of a resource, you know, please feel free to share that. But sadly, I don't have anything.
Sorry, I was muted. Thank you, Dr. Mahal. Maybe one last question to Dr. Lavoie. You mentioned that there's specialized tests to detect or help detect heart disease in women, and just someone was asking what they are.
Absolutely. So it's a great question. And I'm just going to say that you can always connect with your local cardiac rehabilitation program or provincial because oftentimes they'll have links to supports for women or support groups that can be helpful if you have heart disease. In terms of the testing specifically for women, so usually we will put all patients through a specific kind of type of test depending on what their problem is. But for example, if we think someone has heart artery disease, usually they would get some type of stress test first that would tip us off that, hey, it looks like the heart's not getting enough oxygen. So what's going on there? Is there a problem? And if there is an abnormality, then they would be referred for further testing. And usually that ends up being a non-invasive test that has more imaging or an angiogram where we specifically look at the heart arteries. And we're doing a lot of teaching now across Canada to all the docs that do these type of tests. In fact, I was at a meeting last week where we're learning, okay, well, what does heart disease look like? And is there different heart disease in women? And so we actually have had a lot more education and understanding and how we look at the tests and then what tests we might do to figure out, okay, if there's no blockage, maybe there's that INOCA that I talked about, that no obstructive coronary disease. And so there's a number of different ways that we can test that. And there's a number of centers like I said, across Canada that are now doing special testing that can look at that. If patients have an abnormal stress test and they have what looks like a normal angiogram, sometimes that can be helpful in finding the diagnosis. And so, talking to your local cardiologist would be very important if you're concerned or if you have questions about that type of testing. But it is very interesting and important for us to understand what's wrong with us and how we best can treat people.
Thank you. I'm looking at the time. We're over time, so it's the end of the webinar. Thank you, everyone, for joining. I just want to extend a special thanks to, a really heartfelt thank you to our three guest panelists. So, Barb, thank you so much for sharing your story. Dr. Mahal, Dr. Lavoie, for your, of course, expertise and good advice and highlighting all of the gaps that exist, but also hopeful to get to solutions in the short term, of course. So, if everybody, so thanks everyone for joining today's webinar. Just encourage you to visit our website for more resources, more learning opportunities. If you want to follow the conversation, you can also tweet us at Heart and Stroke and use our Heart Month hashtag. So wishing everyone actually a great Heart Month. And thanks everyone for joining and see you all very soon. Have a great day.
Thanks everyone.
Bye-bye.
Stay well.